Hello friends, today we will discuss the Irish guideline number 3, which is the diagnosis and management of severe preeclampsia and eclampsia. Severe preeclampsia should be in high definition unit setting with midwifery care. Labetalol should be first line antihypertensive and hydralazine as second line. Nifedipine should not be given sublingual. Aim should be systolic blood pressure below 160 and mean arterial pressure less than 125. Severe preeclampsia should be given magnesium sulfate to prevent seizures. After delivery, fluid restriction to wait for natural diuresis. Platelet transfusion recommended prior to delivery of any route if less than 20. Methyl dopa avoided postnatally. Follow-up within 12 weeks of delivery. Diagnosis of preeclampsia: hypertension after 20 weeks age of gestation, plus one or more of the following features. Proteinuria, most commonly recognized additional feature. Spot urine protein creatinine ratio (PCR) more than 30 mg per millimole or more than 300 mg per day or at least 1 gram per liter, which is 2 plus on dipstick. Maternal dysfunction, renal insufficiency, serum plasma creatinine is more than 90 moles per liter. Hematological involvement includes thrombocytopenia less than 100,000 microliter, hemolysis or DIC. Liver involvement shows raised serum transaminases, severe epigastric pain, and right upper quadrant pain. Neurological involvement includes eclampsia, hyperreflexia with sustained clonus, persistent visual disturbance, and stroke. Pulmonary edema, uteroplacental dysfunction. Rarely preeclampsia occur before 20 weeks. Mole, triploidy, APS, multiple pregnancy, and severe renal disease. Diagnosis of superimposed preeclampsia. Women with chronic hypertension or pre-existing proteinuria develops features of preeclampsia after 20 weeks. Diagnosis of severe preeclampsia includes eclampsia, severe hypertension, systolic blood pressure more than 160 millimeters of mercury with 1 plus proteinuria, moderate hypertension more than 140 with 2 plus proteinuria plus severe hypertension and visual disturbance, epigastric pain, clonus, platelet count falling below 100, ALT rising above 50, creatinine more than 1000. Note: 2 plus proteinuria or PCR more than 30 millimole per millimole or 0.3 gram in 24 hours. Management includes basic investigations like urea, creatinine, urate, and serum electrolytes, LFTs, full blood count, clotting screen. Group and safe serum blood test should be repeated every 12 hours. If deterioration of parameters occur, blood test repeated every 4 to 8 hours. In monitoring BP every 15 minutes and 30 minutes if stable. Indwelling catheter measure 4 hourly. Measure intake and output. Oxygen saturation measured continuously. CVP measured continuously when present. Respiratory rate, temperature, neurological assessment measured 4 hourly. Fetal well-being assessment. We will check Likert, growth scan, Doppler flow velocity. In fluid management, total input fluid to 80 ml per hour. Cinto should be 30 unit in 500 ml and volume included in total input. Fluid load should be controlled if hypertension occurs. Control using ephedrine in small doses. GA should be avoided as much as possible as it can add risk to delivery since intubation and extubation causes BP elevation. Removal of epidural causes rebound hypertension. Arterial line insertion is indicated in unstable patient and very high BP. Also in obese and if hemorrhage is more than 1000 ml. Postpartum fluid management. Wait for natural diuresis for 36 to 48 hours. Limit fluid to 80 ml per hour. Urine output measured hourly and totaled in 4 hours if less than 80 ml. If input is more than 750 ml in excess of the output, then 20 mg furosemide IV should be given. If diuresis occur in the next hour, more than 200 ml give colloid. If input is less than 750 in excess of the output, then 20 mg furosemide IV should be given. If diuresis occur in the next hour, more than 200 ml give colloid over 1 hour. If no improvement, then renal referral. HELP syndrome. Prophylactic platelet transfusion not recommended unless less than 20. Thromboprophylaxis is anti-embolic stocking. Flotrons, heparin. Low molecular weight heparin should be given until patient fully mobile. Low molecular weight heparin should not be given until 4 to 6 hours after spinal anesthesia. Epidural catheter should be left in place at least 12 hours after administration of low molecular weight heparin, and following removal of epidural low molecular weight heparin should not be given for 4 to 6 hours. Treatment of severe preeclampsia. Systolic blood pressure more than 160 needs prompt treatment. Aim should be systolic blood pressure less than 160 and mean arterial pressure less than 125. Mean arterial pressure is equal to diastolic blood pressure plus 1/3 systolic blood pressure minus diastolic blood pressure. First line is labetalol, 200 mg per oral initial second dose after 30 minutes. 50 mg IV bolus followed by infusion. 50 mg is equal to 10 ml of labetalol, 5 mg per ml. Given over 5 minutes, effect noted after 10 minutes. Bolus can be repeated every 10 minutes until reaching a maximum dose of 200 mg. Labetalol infusion after response to bolus or if only moderate hypertension 20 mg per hour at a rate of 4 ml per hour via syringe pump using 5 mg per ml solution. Infusion rate doubled every 30 minutes until a dose of 32 ml, which is 160 mg per hour, is reached. Contraindicated in severe asthma and caution in cardiac disease. Second line is hydralazine. Bolus is 2.5 mg dissolved in 10 ml of water for injection over 5 minutes repeated after 20 minutes until maximum of 20 mg. Infusion is 40 mg in 40 ml of NaCl to run at 1 to 5 ml per hour, which is 1 to 5 mg per hour. Contraindicated in hypersensitivity to hydralazine, tachycardia and heart failure. Second line is nifedipine. Oral once daily, BD or OD is recommended in pregnancy. Magnesium sulfate protocol. Loading dose is 4 gram IV over 5 to 10 minutes. Maintenance dose is 1 gram IV hourly. Premix solutions 4 gram in 50 ml should be administered as bolus IV loading dose. 20 gram in 500 ml should be administered in pump at a rate of 25 ml per hour, which is 1 gram per hour. No need to measure magnesium level with this pump. Side effects: motor paralysis, absent tendon reflexes, respiratory depression, cardiac arrhythmia. Antidote is 10 ml of 10% calcium gluconate. Note: 97% of magnesium is excreted in urine, therefore oliguria lead to toxic levels. Respiratory paralysis at 5 to 6.5 millimoles per liter and cardiac problem at more than 7.5 millimoles per liter. Delivery should be less than 34 weeks. Give steroids. Benefits of steroids: peaks 48 hours to 6 days. Less than 34 weeks, consider C-section. More than 34 weeks, vaginal delivery if cephalic. Vaginal prostaglandin increases chance of success. Even if baby died, delivery should be expedited by section for mother's interest. Third stage of labor should be managed with 5 units of IV Synto, not ergometrine or synthometrine. Methyl-dopa should not be used postnatally. Beta blockers like atenolol, labetalol, ACE inhibitors, enalapril and captopril, and calcium channel like nifedipine and amlodipine are safe to use in breastfeeding. This is all for the third Irish guideline. Please keep watching for more guideline summaries. Thank you, take care, and bye-bye.